Today, FDA approvals in NTRK fusion-positive tumors, ROS1 positive non-small cell lung cancer, and myelofibrosis, priority review designations in prostate cancer and mantle cell lymphoma, and a breakthrough therapy designation in chronic lymphocytic leukemia. Welcome to Enclave News Network. I'm Gina Columbus. The FDA has granted an accelerated approval to entrectinib, known by the trade name ROS1, for the treatment of adult and pediatric patients at least 12 years of age with solid tumors that harbor an NTRK fusion. The agent has also been approved for the treatment of adults with ROS1 positive metastatic non-small cell lung cancer. The NTRK fusion indication is specific to patients who have a known acquired resistance mutation, are metastatic, or where surgical resection is likely to result in severe morbidity, and have progressed on therapy or have no alternative treatments. The approval is based on data from an integrated analysis of the Phase 2 STAR-TRK2, Phase 1 STAR-TRK1, and the Phase 1 ALKA 372001 trials, which demonstrated a 57% overall response rate in those with NTRK fusion-positive solid tumors. The decision is also based on results from the Phase 1/1b STAR-TRK-NG study. Findings from the integrated analysis show that the responses were observed across 10 solid tumor types, including in patients with and without CNS metastases at baseline. Moreover, the intracranial ORR was 54.5%, and more than 1/4 of these patients achieved a complete response. Additionally, pooled findings from STAR-TRK2, STAR-TRK1, and ALKA 372001 showed that entrectinib demonstrated a 78% ORR and a median DOR of 24.6 months in patients locally advanced or metastatic ROS1 positive NSCLC. The IC-ORR was 55.0%. The FDA has approved fedratinib, known by the trade name Enrebec, for the treatment of adult patients with intermediate to or high-risk primary or secondary myelofibrosis. The approval is based on findings from the Phase 3 Jakarta study, which evaluated fedratinib in patients with primary or secondary disease. Data showed that spleen response was achieved by 37% of patients who received fedratinib at the 400 milligram dose, compared with 1% of patients who were on placebo. Fedratinib also improved the total symptom score by at least 50% when assessed from baseline to the end of cycle 6 in 40% of patients treated with the 400 milligram dose of fedratinib versus 9% of those on placebo. Safety data were also examined from the Phase 2 Jakarta 2 trial, which evaluated the agent in patients with myelofibrosis who were previously exposed to ruxolitinib. The FDA approval for fedratinib comes with a boxed warning for serious and fatal encephalopathy, including Wernicke's encephalopathy, and states that thiamine levels should be assessed in all patients prior to fedratinib therapy, periodically during treatment and as clinically indicated. The agent should not be started in patients with thiamine deficiency. In mantle cell lymphoma, the FDA has granted a priority review designation to a new drug application for zanubrutinib for the treatment of patients who have received at least one prior therapy. The application is based on data from an international Phase 1/2 trial in patients with B-cell lymphomas, a group of patients with relapsed refractory MCL in China in a Phase 2 trial, pooled safety data from 5 clinical trials, and non-clinical data. In the Phase 1/2 trial, the investigator assessed objective response rate with zanubrutinib was 88.9%, the complete response rate was 26.7%, and the partial response rate was 62.2%. In the single-arm, open-label, multi-center Phase 2 Chinese trial, updated findings showed that at a median 13.9 months of follow-up, the median PFS was 16.7 months, and the median duration of response was 14.0 months. The updated ORR was 84.7%, which comprised a 76.5% CR rate and an 8.2% PR rate, and one patient had stable disease. The FDA has granted a priority review designation to a supplemental new drug application for enzalutamide for the treatment of patients with metastatic hormone-sensitive prostate cancer. The designation is based on results from the Phase 3 ARCHES and ENZAMIT studies. In ARCHES, the median radiographic progression-free survival in men with MHSPC was not reached with enzalutamide and was 19.45 months with placebo, translating to a 61% reduction in the risk of radiographic progression or death at a median follow-up of 14.4 months. An interim analysis of OS showed that the median OS has not been reached in either arm, with 39 deaths in the enzalutamide arm and 45 in the placebo arm. A final OS analysis will be conducted after approximately 342 deaths. In the phase 3 ENZAMIT trial, the 3-year overall survival rate in men with MHSPC was 80% in patients treated with enzalutamide plus standard of care, compared with 72% among those who received a different nonsteroidal anti-androgen. In the subgroup of men who received planned concurrent docetaxel, the OS rates were similar regardless of treatment. However, there was a more significant difference in survival in men who did not receive planned early docetaxel. In chronic lymphocytic leukemia, the FDA has granted a breakthrough therapy designation to acalabrutinib. The designation is based on findings from the interim analyses of the phase 3 ELEVATE-TN and ASCEND studies, which showed that acalabrutinib, either as a single agent or in combination, significantly reduced the risk of disease progression or death compared with standard regimens. Regarding safety, the tolerability of the BTK inhibitor in both trials was found to be consistent with prior studies. In ELEVATE-TN, it was announced that single-agent acalabrutinib showed a statistically significant and clinically meaningful improvement in PFS versus obinutuzumab and chlorambucil, and the company ended the trial early due to these positive data. In ASCEND, results showed that at a median follow-up of 16.1 months, the median PFS with acalabrutinib was not reached, compared with 16.5 months for those who received rituximab and idelalisib or arms, translating to a 69% reduction in the risk of progression or death. At 12 months, 88% of patients on acalabrutinib showed no disease progression, compared with 68% in the control arm. This week, we sat down with Dr. Richard Finn of the David Geffen School of Medicine at UCLA to discuss multidisciplinary management of hepatocellular carcinoma.
So liver cancer is a complex disease. Unlike a lot of malignancies we treat, all of these patients come with two comorbidities. One is their underlying liver disease, and the other is their malignancy. The association between liver cancer and cirrhosis is very tight. 90% of patients do have underlying liver disease, and therefore the outcomes for patients with liver cancer will be dictated by their tumor burden as well as their liver function. And so staging systems that are designed to predict outcomes for patients with liver cancer really need to take into account these two factors. So the Barcelona staging system has gravitated to being one of the most commonly used globally, and it breaks patients down from very early stage liver cancer at stage 0 to A, B, C, and D, D being patients who are very advanced and probably ready for hospice care. And the patients with Barcelona D are usually in that condition because they have very decompensated liver disease. They have Child-Pugh C. The Child-Pugh score is a way that we commonly assess liver function, taking into account the bilirubin, the albumin, INR, whether or not they have ascites or encephalopathy. And patients with Child-Pugh C disease are expected to die from their cirrhosis probably sooner than from their liver cancer. Whereas patients with earlier stage liver cancer will have better compensated liver function as well as smaller tumors. Then we break patients into potentially curable, would be the patient with 0 or A disease. Those are patients who could be resected or undergo radiofrequency ablation for well-compensated liver function and small tumors. And then the bulk of patients we see present with Barcelona B or C. Barcelona B being considered intermediate, which are often multifocal tumors in the liver. These patients may have some decompensation in their liver function, but they do not have tumor growing into their blood vessels or tumor outside of the liver, and they also have a good performance status. And then the Barcelona C are those patients who are advanced. These are patients who are appropriate candidates for systemic treatment, assuming that their liver function is adequate. That is to say that they're not the decompensated patients. When we assess someone with liver cancer, really the assessment I have is this patient going to die of cancer or from cirrhosis? And then if it's going to be the cancer component, what is the best treatment for that patient given their stage based on their tumor burden, performance status, and other characteristics? So because liver cancer is complex and there's that interplay between cirrhosis and cancer, really it takes a multidisciplinary team to manage these patients at least the best, giving them the best opportunity for good outcomes. The reason that is you involve the oncologist, the hepatologist. Certainly liver transplant plays a very important role in managing these patients. It is a curative modality. There's few malignancies that we do a transplant for. We would never transplant a lung for lung cancer, but liver cancer does tend to stay in the liver for a while before it spreads outside the liver or before it develops advanced characteristics like growing into the vasculature. So therefore, liver surgery needs to be involved, as well as interventional radiology. Interventional radiology plays a huge role in managing these patients. Patients who have smaller tumors potentially can be cured with radiofrequency ablation if they can't be operated on. Or patients who have multifocal disease in the liver certainly benefit from catheter-based approaches such as chemoembolization, and increasingly Y90 is being used for those intermediate patients as well. So when we see a patient, it's important to get input from everybody. Is this patient be curable with surgery? Are they within transplant criteria? Transplant criteria are constantly changing. So it really behooves us to have a patient, I think, assessed at a transplant program with a new diagnosis. And then are they a good candidate for local regional treatment, or are these patients who unfortunately might just present with advanced disease and need systemic treatment? Many patients we have, I would say majority, present with intermediate liver cancer. So they have liver-confined disease, multifocal tumors. They still might be transplant candidates based on the criteria or if they can be downstage. And these patients will often get interventional radiology-based treatment, chemoembolization or Y90. But those are not curative either, right? And so we know that patients who have these procedures will eventually become resistant to them or stage migrate and become advanced. So they'll either develop tumor outside the liver or they'll develop tumor growth into the vasculature, so that we call this macrovascular invasion. And that doesn't mean just the extrahepatic portal vein, but inside the liver, the vasculature in the liver. Or they'll have a chemoembolization, and on their next imaging, they'll all of a sudden have many new tumors developing, or you can't completely kill the tumor that you're targeting. And those are all times to transition to systemic treatment, right? Local regional treatment, usually patients get a treatment, they're followed, imaged at a regular interval. Often we do what's called TACE on demand. So if they have a new tumor, they get another treatment. But at some point, you start damaging the liver function, right? Every time you do a TACE, you do take away some liver function. And at some point, we can't keep up with the tumor growth, or like I said, it develops characteristics of advanced disease, and that's a time to start thinking about systemic treatment. And the oncologist or the hepatologist who's ever managing that medical component, giving systemic treatment, needs to be involved in the conversation, because it's not readily known that all the new treatments we have available for liver cancer that have been proven to extend survival. And if a patient continues to get local regional treatments to the point that their liver function is compromised, they can't benefit from those treatments. So I think we're looking at solidifying that interaction between local regional treaters, interventional radiologists, and medical oncologists and hepatologists to help define when we stop TACE and start medical treatment.
That's all for today. Thank you for watching Enclave News Network. I'm Gina Columbus.